Hi, I'm Tim Phelan. Welcome to our 12-lead program. I really think you're going to like it. You'll find this to be a very interactive program. Instead of just sitting and looking at a screen, you will identify significant parts of the waveform, play games designed to help you retain important material, and of course, you'll be interpreting lots of 12 leads. If you're like me, you prefer to skip the preliminaries and jump right into the main event. Well, you're only a short time away from being able to recognize and localize acute myocardial infarction. However, before we can get started, we need a quick introduction to the 12 lead itself. So let's spend about 3 minutes looking at the 12 lead. Once you finish this short introduction, you'll be ready to go. A 12 lead is shown here. Note that the 12 leads are arranged in a 4-column by 3-row format. Leads 1, 2, and 3 are displayed on the far left column. The second column displays AVR, AVL, and AVF. Leads V1, V2, and V3 are found in the third column, while V4, V5, and V6 are in the last column. While other formats exist for displaying the 12 lead, this format is by far the most common. Just to make sure you've got it, let's take a minute to complete this exercise. With that behind us, we're ready to proceed to the next module. We're going to learn how to identify ST segment elevation. See you then. The acronym STEMI stands for ST elevation, myocardial infarction. STEMI patients are candidates for immediate reperfusion. That is, candidates for either fibrinolytics or PCI, usually in the form of balloon angioplasty and stenting. While in some cases you can recognize myocardial infarction by the clinical presentation alone, it is always impossible to identify STEMI without the 12 lead. Obviously, it's critical that you be able to accurately and confidently recognize ST segment elevation. We're going to start by learning how to locate the ST segment and identifying which part of the ST segment we use for analysis. Take a look at this complex. As you can see, the ST segment stretches between the QRS complex and the T wave. At first glance, it may seem as if there is ST segment elevation present. In reality, however, there is not, at least not as it relates to STEMI. When identifying ST segment elevation, it is important to realize that the initial part of the ST segment is what we're most interested in. The earliest portion of the ST segment is called the junction point or the J point. It's at the junction point of the QRS and the ST segment where the ST segment analysis is done. So let's take a moment to ensure we know how to find the J point. To find the J point, locate the end of the QRS complex and identify the point where it makes a sudden or sharp change in direction. The point at which the QRS ends and the direction changes is the J point. Now it's your turn. Analyze the following complexes and click your mouse on the J point.
I'm trying to do something. Now, you want me to come up and talk to you in a minute? Okay, I'm doing. I told you
Good job. If you want some additional practice finding the J-point, click here. When you're confident in your ability to find Now that you can find the J-point, the next thing we need to do is learn how to identify J-point elevation. When the J-point is elevated by 1 millimeter or more, ST segment elevation is said to be present. It's a pretty straightforward process to identify ST segment elevation, but there are a few subtleties. For example, take a look at this complex. Following the QRS to the end, we see our J-point is right here. So far, so good. However, when trying to determine if ST segment elevation is present, our instincts could lead us astray. Our eye wants to compare the J-point to the PR segment. But that's not the best reference point because there are conditions that can cause PR segment depression. When that occurs, we could incorrectly conclude that ST segment elevation is present when in fact it's not. A better reference point is the TP segment. The TP segment stretches between the end of the T wave and the beginning of the next P wave. Once you have found the J-point, compare it to the level of the TP segment. In this case, we see that the J-point and the ST segment are level. Now let's get some practice identifying ST segment elevation. The smallest box on the ECG grid is 1 millimeter in size. Elevation of the J-point by 1 millimeter or more above the TP segment is considered abnormal. In the following 6 examples, please locate the J-point, compare it to the TP segment, and determine if the J-point is elevated by 1 millimeter or more above the TP segment. If you would like additional practice at identifying ST segment elevation, just click here. Hi, welcome to Module 4. Here we are going to learn which part of the heart each lead sees. Take a look at this person. Each of the electrodes are picking up an electrical signal and sending it back to the ECG machine. Those signals are combined in specific ways to form specific leads. There are a lot of differences between leads. For example, some leads have one negative electrode, some have two, others have three. Some look in the frontal plane, while others look in the horizontal plane. However, we are not going to a lot of detail about those differences between leads. Instead, we're going to concentrate on one important similarity that all leads have in common. Each lead has one and only one positive electrode. That positive electrode functions as a camera or an eye for that lead. The location of the positive electrode on the patient's body determines which part of the heart that lead sees. So let's go lead by lead, think about the location of the positive electrode, and consider which part of the left ventricle we would see from that vantage point. The heart is not oriented vertically in the chest. Rather, it's positioned as shown here. The left ventricle is cone-shaped and rests on the diaphragm. Specific regions of the left ventricle can be identified. By convention, the left ventricle is divided into 5 regions: septal, anterior, lateral, inferior, and posterior. The QRS complexes in the 12-lead ECG are formed primarily by the electrical activity occurring in the left ventricle. You can think of each lead as seeing a portion of the left ventricle. Which exact portion of the left ventricle a given lead sees depends upon where its positive electrode is positioned. So, let's go lead by lead, determine where the positive electrode is positioned, and which part of the left ventricle it sees.
Leads 2, 3, and AVF share a common positive electrode in the left leg. From that perspective, leads 2, 3, and AVF view the inferior wall of the left ventricle. V1 and V2 are positioned in the fourth intercostal space, one on each side of the sternum. From that location, V1 and V2 see the septum. V4 is positioned in the midclavicular line, fifth intercostal space. V3 is placed midway between V2 and V4. V3 and V4 view the anterior wall of the left ventricle. V5 and V6 remain horizontally level with V4. V6 is placed in the mid-axillary line, while V5 goes in the anterior axillary line. From their perspective on the lateral wall of the left chest, V5 and V6 see the lateral wall of the left ventricle. Leads 1 and AVL share a common positive electrode placed on the left arm. From their location, they also see the lateral wall of the left ventricle.
Well, now you've seen which part of the left ventricle each lead views. The guidelines for STEMI recognition call for ST segment elevation in 2 anatomically contiguous leads. Here, is a color-coded 12 lead that shows you how the leads are organized on the printout. You'll be able to use this later on when you begin your interpretations. Before we go on to that topic,
when determining if any two leads are anatomically contiguous, we first check to see if they are both of the same anatomic group. For example, we know leads 2 and AVF are anatomically contiguous because they are both inferior leads. We would recognize lead 1 and AVL as contiguous since they are both lateral. In other words, two leads within the same anatomic group are considered to be anatomically contiguous. However, there are situations where leads of differing anatomic groups may still be contiguous. So let's look at how to recognize that situation. Please note that we are about to discuss only occurs in the chest leads, that is, V1 through V6. If two chest leads are numerically consecutive, they are also contiguous. Take a look at this. See how the positive electrode for each chest lead neighbors the positive electrode for the next chest lead? Well, since the positive electrodes are adjoining on the chest, the tissue viewed by these leads is also adjoining or anatomically contiguous. In other words, if two chest leads are numerically consecutive, they are also contiguous. Let's try this out. Are leads 1 and AVL anatomically contiguous? Yes. Leads 1 and AVL are contiguous because they are both of the same group. Are leads V2 and V3 anatomically contiguous? Leads V2 and V3 are not assigned to the same anatomic group. V2 is considered septal and V3 is considered anterior. However, since they are numerically consecutive chest leads, they are anatomically contiguous.
our next module is actually a short game which asks questions about what you've learned so far. So have some fun, see how you do. As we said earlier, to recognize and localize STEMI on the 12 lead, we need to know two things. First, we need to know what we're looking for. And second, we need to know where we're looking. In this module, you'll put those two concepts together and begin formulating a step-by-step approach to STEMI interpretation. Let's take a look. Interpreting the 12-lead ECG requires you to go lead by lead, selecting one good representative complex in each lead. When picking a complex to analyze, be sure to select one that has a good steady baseline both in front of it and following it. Of course, don't select a PVC or any ectopic beat for analysis. Once you've selected the complex, identify the J point and determine if ST elevation is present. Continue this process throughout all the leads except AVR. When you're done, answer this question. Is ST elevation present in two contiguous leads? If so, suspect STEMI. You then localize the STEMI based upon the leads showing elevation. To get you used to this process, we have two 12 leads for you to analyze. Start by clicking on lead 1 and analyze the ST segment. Next, decide if ST elevation of 1 millimeter more is present and submit your answer. When you've analyzed all of the leads, your answers will be summarized. Now you're asked if you suspect STEMI, and if so, where it's located. When you've answered those questions, click Submit again to compare your interpretation to ours. Don't worry, you'll get the hang of this in no time. Click here when you're ready for your first 12 lead. Well, that's how you recognize and localize stemming. Not so bad, huh? Now that you've got the process down, we need to give you an opportunity for lots of practice. That's why the next module in this course has 25 more 12 leads for you to interpret. For now, though, let's focus on what you've done so far and practice your skills in Module 7. Go get them.